Hi, I'm Chris Moir. I'm a pediatric surgeon here at Mayo Clinic. I work for children in all aspects of general pediatric surgery, but also in trauma surgery as well. And in that aspect is when I met Cole. For us on the trauma team, Cole's story started just before midnight. We got a call that there was a child who was severely injured out in the field, run over by a tractor and by the trailer behind. He was off to Eau Claire, and Eau Claire was calling saying he needs to come see us. There was a lot of urgency associated with this. He was a level 1 trauma. He was leveled that way because of the report already and because of his physiologic condition in Eau Claire. Those guys were busting their butts for him actually in Eau Claire. They gave me a call directly. The surgeon there said, this is a bad one. Now, with these kind of reports, you know, they can kind of run the gamut, but when you have a surgeon in Eau Claire tell you this is a bad one, you got to sit up and take notice. So we did. Cole was extremely sick. Afterwards, they were telling me that the tractor he was run over has like a 6-foot tire, it's 2 feet wide, and then there was a cart in behind him that also ran over him. Sometimes those are okay. You're on a soft field and a big wide tire and that sort of thing. Not for Cole. He was crushed across the mid part of his torso. So that he had multiple rib fractures, fractured from 3, 4, 5, 6, 7, and 8. Some of those were comminuted. He had a pneumothorax in there, and his liver was crushed. We didn't know all those details. All we knew is that he had a BP of 87/55. He had a heart rate of 132, and his hemoglobin when they first checked it was 8. When they got him ready for transfer, which was really quick, his hemoglobin was 5.6. The Mayo helicopter came, picked him up, and the amazing part of all this is Cole was alert and talking. His GCS was 15, maybe 14. And the helicopter, whoa, drifted down. They recorded 10 as a GCS for him in the helicopter. The team knew, the team picked right up from the guys in Eau Claire. They knew exactly what to do. They had blood on the helicopter. They had plasma on the helicopter. He ended up getting 3 units of blood, a unit of plasma, 3 liters of crystalloid. This is an 8-year-old child getting those kind of numbers. But with that, Cole, who had kind of gone unconscious, popped right back up. The team, we got report right away. For level 1 trauma kids, we kind of like to be there before they arrive. So we're standing at Cole's future bedside at midnight waiting for him. 15 minutes later, he rolls in the door. The team comes in. You know, they're always coming in pretty efficiently. They came in real efficiently with Cole. Came in, put him on the bed. We'd heard all this, we'd heard all these pretty serious signs as he was coming through. The most amazing thing to us is we see this cute 8-year-old boy, kind of curly blonde hair, kind of looking around, talking to us. With a hemoglobin of 5.6, white as a sheet, his heart rate climbing back up again, his pressure dropping down again. He's now had 5 units of blood in an 8-year-old, 5 adult units of blood in an 8-year-old. He's had over 55 cc's per kilo of volume in an 8-year-old already. We did what we do, and we did the primary and secondary survey, but we pressed the button right after that primary survey, probably within about 30 to 60 seconds. This young man is sick. He needs to go to the operating room. In the trauma situation, when you press the button, there's bunches of different buttons to press. And our trauma system here, headed by Don Jenkins and others, have really, really well refined those buttons. It's the most amazing thing. And you know, we're not pressing buttons, but when we say this young man needs massive transfusion protocol shows up. And not only do they show up, but everybody believes and trusts in it. So as Cole's in the emergency room 2-3 minutes by this time. We're seeing his pressure drop. We're seeing his heart rate go up. He's literally getting whiter in the face every minute we look at him. And I, the trauma team leader, says, where's the blood? We need more blood for this young man. And the whole team around me said, it's coming. We got massive transfusion. They're going to be here any minute. complete trust and faith that the system we had worked out was going to work. And sure enough, they came, they hung the stuff, and in the next 2 minutes, you saw his face turn pink again. It was really phenomenal. The other button we pressed was the button that says he's bypassing all our usual stuff. He's not going to CT scan. He's not going to the ICU. He's not going to get other x-rays to look at his rib fractures. He's already got a chest tube in now. We knew blood came out with that chest tube, but we've got a quick chest x-ray. We're bypassing all those steps. He's going right to the operating room. The event we were hoping to avoid is having to operate on Cole with a large incision. His tummy was kind of containing this massive amount of bleeding that he was doing. We knew that as soon as we opened him up, the blood would just no longer be contained and he would lose his blood volume almost instantly. Then, for most of these circumstances, when we looked this up, the mortality rate is 60 to 70%. If we could get this done without doing a major surgery, Cole would survive. So that was the tension there in the operating room. The tension was, can we do something that's minimally invasive, exactly spot on to what he needs to have doing without putting him through a procedure that has a 60 to 70% mortality to it? So there are a lot of people in there hoping and praying for Cole. It's tense, but this is the job we do. Just getting Cole under anesthesia, you know, with him having a belly that's tense, and remember, he's got fractures 3, 4, 5, 6, 7, and 8, 2 or 3 of those levels multiply comminuted. His lungs are already damaged from the fractures. He may have also aspirated, so both lungs actually have infiltrates in them from the aspiration. He's got a chest tube in there. He's bleeding inside his chest. He's got air inside his chest. He's got a belly that's full of at least 5 or 6 units of blood, plus plasma, plus crystalloid, and we're asking our anesthesia colleagues, would you mind please putting him asleep? You know, and they say, okay, and they'll do that. Then we bring in our IR colleagues. Remember, this is now 12:30, quarter to 1 in the morning, and our IR colleagues are coming in from home, and their answer is, it says, what's going on with this child? This is on the telephone. What's going on with the child? I tell them, they say, okay. When they came in and they got their catheters in and saw where he's bleeding from, probably the best indicator of how bad it was the silence. A lot of times when we find it, it's like, yes, we found it, great. And this one, it was like, oh. I mean, he was bleeding that fast. As soon as they put the contrast in, you could see it just whoosh outside, track down underneath the liver, and go into the rest of the peritoneal cavity. I mean, it was that fast. They described it in the report as extremely brisk. We described it in different ways in the operating room after that initial, oh my gosh, silence. But then to a credit to Dr. McPhail and his team, they persisted for the next 4 hours, making sure, I mean, it wasn't just one point that was bleeding, it wasn't just 2 points were bleeding, and by the way, the artery that was bleeding was an anomalous artery. It didn't come off in the usual place. They figured that, and they're like, well, this is the way it is. It's not like, oh my gosh, this is a different looking artery. They found where the different artery was. They found the 2 different places that it was bleeding. They got that all concluded. And it was totally professional, right up to the very end when, you know, after, you know, this is their job, and they put the coils in, they check afterwards. We're all sitting there checking with them, kind of wondering, the surgery team's ready to go, we're ready to open up his abdomen, and they put the next coil in, check to see if it stopped the bleeding, still bleeding. Put the next coil in, actually some of the coils just went right outside the artery right away too. You can see it's still bleeding. Coil after coil, bleeding's going down, still bleeding. We're getting to 4:30 in the morning, another coil in, still bleeding. And then they put in the last coil, check, no bleeding. And then there's another silence. And so I say, so, you gonna check that again? And he turns to me and says, no way. I'm not going to check that again. It stopped bleeding. He did. But it was just sort of a moment of, yes, we finally got it done. When this kind of severe injury with this kind of effect on the body happens, even if you're 8 years old, you get extremely sick from it. You don't just stop your bleeding and say, great, and go home. Your body now suffers all the consequences of being so sick. The amazing thing is through the night, during a time when we are naturally tired, he got care second to none. By the time he was out of the operating room and now to the peds ICU, he had a urine output of 2 cc's per kilo per hour. Fabulous urine output. He was intubated, ventilated. He had 100% oxygen saturation on low settings. His hemoglobin was in the 10s, 11s. He got platelets, he got fresh frozen plasma, his fibrinogens were fixed, his coag factors were fixed. He came out of that extremely difficult time like a rock star. And yes, he was healthy and could have managed that, but it was the team that recognized all the changes that were happening with him, anticipated all those changes, and got him cruising to the unit. Really a fabulous job done by everybody.